Hello, and welcome to this session titled Scaling Insecticide-Treated Nets from Obstruction to Opportunity with Cordelia. I'm Zukit Chen, and I'll be the MC for this session. Following Cordelia's presentation, we'll move on to a live Q&A session where we will respond to your questions. You can submit questions through the swap card live discussion feature. Then, after 50 minutes, we'll bring the session to an end. But now, I would like to introduce our speaker for this session. Cordelia is an independently affiliated global health policy researcher. Cordelia's research broadly focuses on understanding how change happens and how context shapes policy, program implementation, field building, and other activities, processes in the health sector. Previously, Cordelia has worked with the Center for Global Development, primarily on the institutional advancement team, and with the global health policy team. Cordelia has a master's in global health from Duke University and a bachelor's in history from Oxford College. In this talk, Cordelia will explain how insecticide-treated nets, or ITNs, considered exceptionally cost-effective and one of global health's best buys, increased from roughly 5 million nets distributed annually to more than 200 million nets in the span of 1 decade. This session will review the main causal factors that enable global ITN scale-up to occur in the 2000s, while also discussing the multiple barriers that prevented faster scale-up early on. Cordelia, over to you.
Thank you so much for that introduction, and I'm really excited to share more about this work, and thank you to everyone in the audience who is joining us. So this is going to be about the story of scaling up insecticide-treated bed nets in the 2000s, and this was work that was supported by the Urban Institute and Open Philanthropy Project. And this is also a project that is almost 2 years in the making, so I'm very excited to reach this culmination point and to say that the case study will be available online next week. And definitely we'll be skipping over some of the finer details in this talk, but encourage you to check it out if this piques your interest. So to set the scene, okay, so to set the scene, I just wanted to start with this graph, which is the cumulative global ITN distribution from 2004 to 2014. And so we have this lovely curve upward, which this is remarkable in itself, this distribution, but what it represents is even more remarkable. Through the distribution of this many million nets, along with other tools to treat and diagnose malaria, this led to a 40% reduction in malaria deaths in this time period. And ITNs alone also prevented an estimated 450 million malaria cases. So an absolutely incredible tool. It's also very cost effective. So it's, for these and other reasons, considered a best buy in global health. And the question that we're addressing and that I'll hope to cover today is, how did we get here? How did this happen? So just to give a quick outline of what I'm going to talk through today, first is just what are bed nets and why are they important, then getting into the foundation of going to scale, being able to go to scale, then talking through some strategies to get to scale, and as we'll see, there wasn't really a lot of money initially to do that. Fourth, we're going to talk about the sort of stars finally aligning where really some of the enabling factors came together, and then finally talk through some of the what really caused ITN scale up and some implications for the future. So what are bed nets and why do we care? Very briefly, malaria is a life-threatening disease that is caused by Plasmodium parasites transmitted by Anopheles mosquitoes. There are multiple species, but the deadliest is P. falciparum. It's the dominant species in Africa and also the deadliest. And as you can see from this map, that it truly is a global disease. Most of the earth has been affected. And for the countries that were able to eliminate malaria, they did so through a combination of tools, things like vector control, broader socioeconomic development, other public health measures, as well as, of course, prevention and treatment for malaria. So just looking, and again, that has been eliminated in some places in the world. I say for now here because just this year in the US, we had our first locally transmitted cases in 2 decades. So, I mean, controlling malaria remains a challenge, but truly Africa is where it bears the brunt of this disease burden. As you can see, the vast majority of deaths and cases occur here. And just to note that the year that I have here is 2000 for the graph on the left, because that's a very important, that's sort of marking the turning point of when we're trying to get to scale. And just some other things to keep in mind on malaria: it's among the leading causes of death in young children. And in fact, most of the people who die from malaria are young children, and we see about 250 million cases every year. So this is also just to underscore the scale of the problem and the potential health impact you can have if we can do something about it. So what was being done? So in the 20th century, there was the development of a few promising new tools, including chloroquine, which was an anti-malarial drug, as well as DDT, which is an insecticide. And these really sparked some ambitions to eradicate malaria globally. So then we had the malaria eradication program starting in 1955, launched by the WHO. It was in 46 countries, but notably not many African countries, even though that's where the malaria burden was highest. And part of the reason why is because a number of institutions at the time had this sort of fatalism about Africa, about malaria in Africa, and thinking it was impossible to control malaria there. So going into the end of this century, we have not a really great toolkit to combat malaria. And then also we have this context of the emerging HIV/AIDS crisis, which obviously in the 80s and 90s and then going into the 2000s was a huge health crisis. We had a global recession and a debt crisis, and then we also had the rise of neoliberalism, which had some negative effects for scaleup, ITN scaleup, which I'll get into. So taken all together, this created what one of the experts I spoke to for this project, kind of a landscape devoid of hope. And that's when we have our beloved bed nets, which were a promising new tool amidst this sort of hopeless landscape. And they're great for many reasons, but one of the reasons is it creates this sort of dual purpose of both protecting the person who's sleeping underneath the bed net at night, because mosquitoes bite at night, though also to note they are adapting and starting to bite in the day. It also creates sort of a community benefit, because the insecticide that kills the mosquito on contact also serves as a vector control. And similarly, how when you have a sufficient number of people who are immunized against measles in a community, that creates community benefit. So it's this great in that way, these multiple benefits that it confers. And then also it's relatively cheap, very cost effective, and now it's a key component of many malaria control programs. So let's look at the origins of how bed nets came to be understood as such a powerful tool. So this is just a very brief synopsis. There was lots of other research that I could highlight, but these are some of the really key things that were coming out in the 1980s and 1990s that really cemented the evidence base for bed nets. 1980s, that's when the first trials were happening, and that was really measuring the malaria exposure reduction from nets. 1991 is when we have our first study that's looking at child mortality reduction. This was a very important shift in what was being measured, and the results were incredible. We had a 63% reduction in child mortality. Those are obviously very huge, significant numbers, and that actually influenced the Gambia to adopt a national net program that year. But the question, of course, was then, how generalizable these results were. So malaria is a very local disease, and it wasn't clear at that point if that sort of effectiveness would hold in other contexts. So there were 4 big RCTs that were done elsewhere in Africa. Well, another one in the Gambia, then one in Ghana, one in Burkina Faso, and one in Kenya. And these showed a little bit more variable, not all as amazing at that 63% reduction, but still pretty good. And then 1998, that's the first of several Cochrane reviews that looks at all the evidence to date, and pretty incredibly finds a 20% reduction in all-cause child mortality, not just malaria mortality reduction. So basically, the takeaway from this slide is that by the end of the 90s, going into 2000, really, really clear evidence that the ITNs were a life-saving tool and very important part of malaria control. And then also in the 90s, we have, again, this is not in any way comprehensive, but just give a flavor of the kind of conferences that were happening and commitments that were being made. We had 2 international conferences, one in Senegal, one in the US. We have the Director General of the WHO declaring malaria top priority. We have this multilateral partnership, Rollback Malaria, established. We also have ITN coverage set as an indicator for doing something on malaria that's committed to by heads of state, by other key policymakers in the Abuja Declaration, MDGs. Wow, great. We have so much great momentum happening. Looks like we're going to go to scale, right? Well, unfortunately, no, because the context going into the 2000s was really, really limited funding for malaria. So you can see on the left that most funding for global malaria was coming from governments or out-of-pocket spending. And in many malaria endemic countries, they were also very heavily indebted. So they didn't really have, even though the bulk of the money that was funding malaria was from governments, this is also not that much in the scheme of everything else that governments have to pay for. And then just to zoom into the development assistance for health that was available for malaria, you can see as well from this graph on the right that it's really negligible before the mid-2000s. Afterward, we see it shooting up, but super low. And this is basically the same information, just in a different format, or just slightly different information. And it's just really to underscore this point that the donor commitments for malaria at this point in time were really, really not much. And also to note that malaria, of course, was not the only disease that was affected in this way or had this kind of neglect. There were definitely other diseases. And this was also, importantly, before the advent of the Global Fund, of PEPFAR, PMI, the big funds we know of now. And I think we should talk about it to see, what's going on here. So we have this amazing evidence. We have policymakers committing to act, but really it's just rhetoric without any action because no funding, no scale up. And I just want to underscore that this was a choice. Malaria was acutely neglected in this period. This period was also plagued by inaction. And we can see on this graph on the left that in the African region in particular, mortality from malaria is just shooting up. And this is a bit of a crude comparison, but it comes from a source that I read for this project. So in 2000, this graph on the right, the total development assistance for malaria was $100 million, which is very small when you think of the billions of dollars that are now mobilized for malaria. And by comparison, the production budget for the movie Titanic was double that. So again, a crude comparison, but just to sort of put in popular terms the discrepancy. So, amidst this context, what are ways that we might go to scale? So basically two strategies emerged. The first that came along was social marketing, and the idea was to subsidize nets, or to socially market nets and then subsidize to the people who are most vulnerable, which included pregnant people and children under 5. And then the other main strategy, was to mass distribute free nets through integrated national campaigns. And I'll explain what integrated means in this context in a moment. But just to say that these two approaches were shaped by two different philosophies. For social marketing, it was shaped by sort of a value for money frame, which basically asks the question, we have limited resources, many health needs, can't cover everyone. How do we get the most health impact with the money that we do have? And the mass distribution model was informed by more of a health for all frame, which basically says, we have this life-saving tool, we have thousands of people dying daily, most of whom are young children. So let's just treat and fund nets like a public good. And value for money and health for all are not mutually exclusive, but the debates around these strategies really kind of hindered scale up. So just to note that. So let's run through the basics of the social marketing approach. So it was very much responding to the fact that there wasn't really money to speak of to go to scale. So the thinking was, let's think through ways to build a sustainable model where we're not relying on donors in the long term, and we're also capitalizing on this existing manufacturer base in Africa for the nets. And the main activities were to build a commercial market for nets through social marketing, to give subsidies to, as mentioned, the most vulnerable groups to malaria, and then also in the meantime be growing the African manufacturing base. And the main actors who were doing this were Netmark through USAID, and then Population Services International with the DFID funding, which is now FCDO, but that's the UK government's foreign office. So in terms of results, what we're seeing is Netmark got out in its first 7 years 15 million nets, which is about 2 million on average. Certainly nothing to, that's significant, but when you think of the scale of the need, not that much. And a study that I'll reference in the next few slides as well that compared coverage rates from different distribution models. It found that for commercial distribution, it was only about 7.1%. So turning to the mass campaigns approach, and just to note too on terminology, I might say mass campaigns, integrated campaigns, mass distribution campaigns, all sort of referring to the same thing. But really it was responding in part to the fact that coverage rates through social marketing were so low, but it was also in response to evidence that was becoming clearer that poverty and net cost were the biggest barriers to net use. And it also was responding to the fact, as we saw earlier, that the mortality trends were going in the wrong direction. And so let's just treat this amazing tool that we have like a vaccine, like a public good, and just figure out a way to work through the public sector to get it out. So the main activities were to integrate the distribution of free nets with other ongoing routine child health survival campaigns. So those included things like measles vaccinations, distributing deworming pills. And the main actors who were doing this were the International Federation of Red Cross and Red Crescent Societies and their affiliates, as well as Canadian International Development Agency, or CIDA, and the U.S. Centers for Disease Control and Prevention. And so one of the earliest campaigns that did this, the evaluation of it found that the net ownership increased from 16.7% to 81.1%, and this was in Zambia in 2003. So that's pretty phenomenal, definitely very different to the 7.1% we just saw. And then in the same study that I referenced in the last slide for the mass campaigns approach, it was a 67.3% coverage through free distribution. So again, very stark difference that we're seeing in coverage. So just some other context in terms of what's informing people thinking about scale up. So as mentioned, you have lots of young kids dying from a preventable disease. We have a lot, we say that the net is on average only $5, but even highly subsidized nets could be as low as 50 cents. But at the same time, in many places where malaria was endemic, poverty was very high as well. So the share of a household's income, even 50 cents, that's still actually a very high price and was not affordable for many people. And at the same time, there was also very low coverage. Only 5.1% of children under 5 in endemic countries had an ITN in 2003. So that context, along with some other things, is part of what really influenced the eventual shift to just get the nets out through mass free distribution. Some other things to highlight that sort of helped along that shift was the 4th annual Multilateral Initiative on Malaria Conference in 2005 in Cameroon. Multiple people I spoke with for this project cited this conference, and in particular, a debate at this conference was really an inflection point on this debate about what strategy was the best strategy to go to scale. And then that study that I've mentioned in the previous slides, those results were from Kenya specifically. Excuse me. And those found much better coverage through the integrated campaigns, and that actually, the evidence from that campaign was cited in the WHO's policy decision to formally recommend integrated mass campaigns in 2007. And then one other important thing from that year in 2007, an RCT led by Jessica Cohen and Pascaline Dupas showed that the price was a big barrier to net use and net access. And this just sort of backed up what was becoming clear without that RCT, but really sort of formalized and crystallized that knowledge. And there was other research that was happening as well around this time that really was showing that cost was a big barrier to access certain health products and services. And countries themselves, also endemic countries themselves, were also more interested in the free distribution approach, but couldn't afford them in that situation or in that context. So the creation of new funding sources through the Global Fund really sort of helped change that, which we'll get into. But first, let's back up again. So the lack of funding was far and away the main problem in terms of being able to go to scale. But what was sort of shaping that debate, along with the very real resource constraint? So in the 1980s and 90s, the World Bank was starting to, or had required for loans, the introduction of user fees, which basically displaces some of the costs of healthcare onto the healthcare user. So, and user fees, just to say, are different from social marketing, but here I'm just sort of treating them somewhat conceptually equivalent because they both result in charging people for health products. But in the case of bed nets, as we just saw, charging any price for nets actually created a pretty significant barrier to access, particularly among those who needed them the most. So another sort of consequence of this was what one person I spoke with for this case study classified as a sort of allegiance to theory over practice, or making policy decisions based on untested economic theories. And so in the case of bed nets, there was this pervasive idea that if you charged people for nets, they would value them more, they would use them, they would be more likely to use them correctly. And this was based on economic logic that certainly might hold in other contexts, but hadn't been tested in the health sector. And then when it came to be tested in the health sector, it didn't pan out that way. But because this was the institutional position of many development agencies, academics, sort of leading entities, there was a lot of resistance. So with the advent or the sort of emergence of the universal health coverage movement in the 2000s, that really started to shift things, and that benefited scaleup, but certainly not without a fight. As you can see from this text box on the right, the WHO in its press release announcing its decision in 2007 to formally recommend integrated campaigns cited the inability of the international community to reach a consensus as informing the delay. But okay, so those debates and disagreements about the optimal scale-up strategy were hindering scale-up, but let's turn to some of the things that were more enabling. So as mentioned, the Global Fund, the creation of that new funding source really changed the terms of the debate around what were optimal strategies, because it just unlocked a tremendous amount of new resources for malaria and also, of course, AIDS and TB. It was formed as an emergency response in 2002 as a health commodities fund to really just get these products out to people who needed them. And critically, the inclusion of malaria was by no means guaranteed. It was through the advocacy of Rollback Malaria, for example, of the African Union, of African heads of state, to include malaria in the Global Fund. And again, just to really underscore that it did, because of the amount of money that it mobilized, it changed the terms of debate and made it a lot easier to say, let's just get the nets out. I'm going to skip over a little bit of the purchasing power and volumes because I'll get to that in a next slide, but just to say again that by 2007, the Global Fund supplied 64% of all global funding for malaria, and by 2010, that number was up to 70%. And I think it's still today pretty high, but clearly it's just such a huge source of financing for malaria control. So just I'm going to try to cruise through this slide, but basically manufacturing capacity was also really, really important because before 2007, there were only two quality assured manufacturers, Sumitomo Chemical with its Olisat and then Vestigard with its Permanet. And these two types of nets were long-lasting insecticide-treated nets. And this was different than other kinds of ITNs because the insecticide was coated or weaved directly into the fiber, which means you didn't have to retreat them, which previously you did, and that created some barriers to access and was just a major innovation. But there were only two companies who had gone through the regulatory approval by 2007. So the creation of the Global Fund and then later the President's Malaria Initiative, the volumes that they were able to procure were so helpful in terms of assuring a market, and that helped bring more manufacturers in, create more competition, and help bring down the unit cost. So this is also a sort of complicated side story in the story of bed nets of how this relationship between the demand and the supply, because donors also needed assurance. So they needed to know that were there even nuts available to procure in the first place before they're putting out these orders for huge volumes. But also something that was really important for signaling a market for nuts were these early integrated campaigns. So on the right, this map of Africa, we have Ghana, Togo, and Zambia in green, and these were the first mass campaigns that were led by the Red Cross, CDC, CETA, Ministries of Health, and other partners. And this showed proof of concept and then proof of scale. And in fact, the evidence from Zambia and Togo actually led the Global Fund in 2005 to approve its first large-scale integrated mass campaign to Niger. So that directly influenced their decision. And then, as we've discussed previously, the study that looked at evidence of a few different distribution models, and the country that happened in was Kenya, that actually also directly influenced the WHO to change its formal policy. So really just here trying to emphasize that the evidence generated from these campaigns, these early campaigns, were really path-breaking and did influence funders and the WHO. So in this way, the Canadian government and IFRC are kind of the unsung heroes in that story. So just to note that. And then the last thing I just want to say on enabling factors is, although I've highlighted a few specific actors and a few specific things, this truly was a collective action effort, and it was all about coordination. So many of the experts I spoke to really emphasized the sort of collectiveness that it took and the coordination it took to make this happen. And also the advocacy and championing at pretty much everywhere, every major international forum, and just the sustained effort that it took to do this. So just to underscore that. So just moving into wrapping up, what can we say caused ITN scale up to happen, and what are some things we might learn for the future? So I definitely did not cover all these factors in this presentation or as in depth as they're in the case study, but the case study does cover all this and more, so I encourage you to check that out. But just to recap some of the things we talked about the issue of funding, we talked about collective action, the importance of evidence, in particular RCTs and the data generated through large-scale integration campaigns. We talked about production and manufacturing capacity. We talked about reaching consensus on the optimal delivery strategy, LLINs, policy and technical guidance. And I'm putting these all out here just to also, again, emphasize how interconnected this all was, how contingent it was, and how kind of complex it was. And really, it was everything coming together and working together to really be able to put the pieces together for scale up. But of course, there were absolutely things that were constraining scale up. And again, I didn't cover all of these in this talk, but they're discussed in depth in the case study. But just to highlight some of the things we talked about was number one, the acute funding gap. But one thing I guess we did not get too much into, but definitely is what gave rise to that acute funding gap. And certainly a big piece of it was the lack of political will at international institutions to control malaria in Africa. So as mentioned, there was definitely a lot of inaction, a lot of neglect, a lot of sort of fatalism, and that is definitely a thing that influenced the funding gap. Then we also talked about the operational and logistical challenges and the lack of consensus on delivery and the role of sort of entrenched ideas about what was the best way to deliver health products. And something I just wanted to bring up, because I read this yesterday and I was thinking, wow, this really overlaps a bit with this story. I read in DevEx that a similar sort of issue is plaguing efforts to give cash directly. So this Malaysian doctor and academic, Jamila Mahmood, was quoted saying, instead of looking at how you grow the pie, people are focused on how you divide the pie. And she was saying that infighting among delivery agencies are hindering efforts to scale up giving cash directly. So just saying that to say, or bringing that up to say that clearly these kinds of issues are alive and well. They're not specific to malaria. They're not specific to bed nets. So just something to note. And on that note, maybe thinking, what are some thoughts we might take, or some lessons we might take from the scale-up efforts in the 2000s and apply them to today? So we're really actually running into some of the same issues because there's now a new class of LLINs, and or same sort of questions and conversations that are coming up about how best to scale them. But really, the first thing to highlight is that malaria has never been fully funded. And in fact, as of 2022, only half of the funding goal has been mobilized to do everything that we want to do to be able to control malaria. So this is very much an ongoing fight. We're not in a place to like rest on our laurels and say the job is done. It's still very much something that a lot of work needs to be done. And particularly too, in the context of, an emerging debt crisis that's happening and global recession, we're dealing with some of the same issues. And then secondly, just on research, so a criticism that several experts I spoke with for this project raised of the scale-up efforts in the 2000s was that the focus on health commodities kind of sidelined research. And there's really a risk of that or there's detrimental effects of that because malaria continues, or the bugs that cause malaria continue to evolve. We're seeing resistance. We need new tools. So it's very important to invest in ongoing research. And then the last thing is just on strategy, is thinking about in controlling malaria now into the future, thinking again, it's a very local disease. What is the future of bed nets? What is the right delivery strategy in certain contexts? And one final point on that too is that bed nets are absolutely not a silver bullet. They're one tool amongst many tools. And so thinking about how we can really get ahead of malaria will require probably new and better tools as well. So just to sort of take a step back and think about some broader takeaways we might have from this story. So I want you to just think back to that graph at the beginning of this presentation, the lovely curve upward of cumulative bed net distribution, and just visualize that image and think about what those nets represent, which is all the number of lives that those nets saved. So in that way, the story of the bed net scale-up is truly remarkable. It's a remarkable success story. But what I hope you also walk away from this conversation with is a greater appreciation of how before it was a story of success, it was a story of failure, and how as much as it's a story of how to do the most good, it's a story of what gets in the way of how to do the most good. And I just want to touch on and emphasize a few further reflections from this case study. So I put this starry night sky as the background for the slide for a couple of reasons. One is that a lot of the people I spoke with for this project use the term stars aligning to describe scale-up as this sort of serendipitous, something ineffable about the moment of things coming together to enable scale-up. But also the second reason is because, when you look up at the night sky, it's something that really instills wonder and awe and makes you feel like anything is possible. And to bring it back to ITNs, so, researchers had generated all this great research, policymakers committed to act, yet there was no funding, no money to actually go to scale. And it's the question is, well, what is behind that? So in the words of another expert who I spoke with for this project, he said that fighting malaria was going to cost a lot of money, and people didn't have the imagination to think we could go get that money. And I think that word imagination is really important because it makes me think too of something else in the health sector and in the development sector that often gets kind of obfuscated, which is that health is political, health financing decisions are political, and they're very much shaped by the imaginations of, or what is deemed possible by, the people in power. So the world that we have is very much a consequence of the choices people make. And so that begs the question of what other choices might we make? And so The last thing I want to leave you with is something that I think, of course, applies in this particular story, but I think could also apply to a number of other things, and other areas in health and development, as well as our society more broadly. And that's, and I also want to shout out the science writer Ed Young, because he is the one who first mentioned this, and I just love this idea. So, but the basic idea in this idea, the Stockdale paradox, is that we have to be both clear-eyed about what the barriers and constraints are, or basically confront the most brutal facts of our current reality, and at the same time have unwavering faith that you can and will prevail in the end, regardless of the difficulties. So idealism is also really important. Pushing the bounds of what might be considered possible, also really important. Because, when you think of the story of the bed nets, in 2000, the amount of funding that was mobilized for malaria by 2010 would have seemed unimaginable. So there's that. And then the last point I just want to say is just to sort of echo something that several experts I spoke with said, which is basically to just not lose sight of the fact that behind the numbers are human beings. Okay, so that is all I wanted to say, or what I had prepared. Thank you so much. I hope that was informative, and definitely happy to answer any questions.
Yeah, thank you so much for your question. Thank you so much for your presentation, Cordelia. I see that we had a number of questions submitted already, so let's kick off with the first one. And just a reminder to everyone, do drop your questions on the Swapcard app under the live discussion. So the first question, given the development of new malaria vaccines, do you expect vaccine distribution to be a more cost-effective solution to combat malaria than net distribution? Or are the distribution of vaccines and nets complementary? I can repeat the question for you.
Oh, thank you. Thank you so much for that. I think, yeah, that's a really great question. I think the advent of vaccines, and in particular having two that are also continually in development and getting better. I don't know exactly how effective, what the efficacy is of the two vaccines, but I think the newer one, I think R21, is really quite effective. So I think that does change the cost effectiveness, because it depends too, and this I'll definitely say, this is broaching what I know, so don't take my word on this, but I'm not sure what the durability of the protection is from those vaccines, because if they are really long-term, really long-lasting protection, that definitely would change the thinking. But I think it's a great question. Yeah.
Okay. On to the next question. Next question is by Lian. Lian asks, what role did the Against Malaria Foundation, often touted as a high-impact EA charity in the global health space, play in all of this?
Another great question. So in the course of researching this case study, I didn't come across very much on Against Malaria Foundation. I know they were founded in 2004 among other organizations that were formed with the express purpose of getting bed nets out. And just to say that that is not necessarily a reflection on their value or anything like that. I think it's just the specific, in terms of just getting the numbers out and getting to scale, it was, yeah, there were other actors that were maybe had more of a direct causal role. But I think one question too is because, the Global Fund was the one funding these activities, but there were lots of other sort of partners on the ground distributing nets. And so I think that's something that, so I should not have a super clear answer on that, but.
Thanks for the attempt, Cordelia. The next question is by Rishi. Rishi asks, what role does the state play? Could the measure of success which has been achieved have still occurred given the different political or economic environment? How should lessons learned be factored into future plans?
Okay, so the role of the state,
given the different political economic environment, and how should lessons learned be factored into future plans?
Good question. Okay, so I think the role of the state, early on, it was mostly governments that were funding malaria. And so I think Well, I'm going to maybe answer this question in a different way than maybe you asked it. But basically, I think, governments do have a duty to provide certain benefits to their citizens. And so if they're not providing those benefits, there is maybe some accountability that the citizens can enforce, because I think their role, one of the concerns too is that so much funding for malaria, as we saw, is coming from the Global Fund. Granted, it's a multilateral fund that a lot of state actors are feeding into, but in terms of like government responsibility for their citizens, it does sort of, I don't want to say let them off the hook, but there is a question of sustainability and accountability and who's sort of in charge of that. So, but it's a great question, and I don't know that I've done it justice. But then the third question was lessons learned for future plans.
To be factored into future plans. Yeah.
Yeah. I mean, honestly, I think a lot of it seems like I'm less knowledgeable about some of the specific issues that are happening now in terms of malaria control. But I think what we're seeing from what I know is that there are a lot of the same issues repeating themselves in terms of how do we distribute these particular products in these particular places. And I think one key lesson is that in the 2000s, the idea was just get as many nets out, the cheapest cost net, to as many people as possible, because there was just such a huge coverage gap. And now there's such a net culture already existing that, you can have a more tailored approach, you can have a more nuanced approach. So I think for one, it's actually learning from the past. I think it's looking at, okay, what went wrong, what sort of like created issues, and actually changing your actions in accordance with that, because I think that was part of the problem with some of the early scale-up efforts.
Okay. Thanks so much for the answer, Cordelia. The next question is by Andrea, and Andrea asks, what is the life of an ITN? When do they need to be replaced? How long is the insecticide effective? Do the needs need to be retreated with insecticide? I can repeat the questions. What is the life of an ITN? When do they need to be replaced? How long is the insecticide effective? Do the nets need to be retreated with insecticide?
Yeah, so
maybe say more about
yeah.
The
So when insecticides were first developed, they did have to be retreated, and generally they had to be treated every 6 months or so. And the way that happened was in sort of like a communal re-dipping session, which would be hosted maybe by the local community health clinic or something. Then little individual insecticide packets were developed where you could do it yourself, but still most people were retreating nets going into the 2000s. With LLINs, you don't have to retreat them, at least in terms of the ones that were being used in the 2000s. And they were supposed to last for 3 years. I think now that was something else that came up actually in conversations with experts, was that whether they actually last the intended 3 years is kind of a thing that is a question that is open, I guess. And in terms of the durability of the insecticide, I think that's part of the issue. But for this generation of nets, the next generation of nets, I definitely am less knowledgeable on that. So I don't want to say too much.
Yeah, thanks for the time, Cordelia. The next question is by Scott. Scott asks, are there other historic scaling up case studies you would like to see conducted?
Oh, good question. I mean, honestly, so many. I just love I think the history is so important, and really, oh my God, because there's such a big no-do gap in global health, and part of it is just not looking at the history of things. I think in malaria in particular, so as bed nets were being scaled up, we also had the scale up of artemisinin-based combination therapies, which is currently the first line antimalarial drug to treat malaria. And that was the story of that also is really fascinating. It was discovered in 1972 by a Chinese scientist, and it was based on ancient Chinese medicine that had been used for millennia. But it was discovered in 72, and then it wasn't until the 2000s. That's another sort of why did that take so long to be able to scale up. But now also we're unfortunately seeing resistance to this amazing class of drugs, so we're going to have to figure out some other drugs. So that's one, yeah.
I see. The next question is, what inspired you to focus on global health, and how did you become involved with this case study? Do you have advice for people who are looking to get into the field?
Okay, so what got me
Inspired
into
you
global
to
health? Yeah.
global health? How did you become involved with this case study? And just do you have advice for people wanting to explore the same career path? So yeah, say more about your career.
Okay. So I'll answer the second question first. So in terms of how I got involved in this, the person who's leading this at Urban, Ben Soskis, I actually worked with him on another case study that was looking at the Center for Global Development's role and value for money and sort of building that field. And so he reached out, and this was a great topic. So it was just a very natural alignment. I think in terms of, and the Urban Institute also has a whole other series that's supported by Open Philanthropy that has case studies like this. So also totally encourage you to check that out. In terms of global health, I think health ends up being where you see a lot of the problems with society. I think it's like such a nexus of where you can have impact, because so many things get intersected, get affected by health. And if you have ill health, that can then also create so many other challenges for you as an individual and collectively. So I think it's just if you want to have impact in the world, it's such a good thing to focus on. My advice, okay, so I really think this is maybe me getting on a little bit of a soapbox, but I really think it's important for anyone who is in the field of health or development truly to remember that health is political, and that, yes, it's so important to try to be impartial, but we have to also remember that like people are fallible, people are emotional, we try to be rational, but the way that decisions get made are not always made on reason. So I think just like sensitivity to that is really important. I don't know how much that answers your question about like career wise what to do, but just I think that's kind of my advice.
All right, thanks, Cordelia. We do have time for only one last question, so I'll have to skip over some folks' questions, but there is one good one to note, which is any recommendations for further reading about the ITN effort, or like any, I guess I'll just open the question to any resources that you'd like to share to audience to check out, and I'll try to diligently look for it and drop in the chat.
Okay, definitely. So I think the RCT by Jessica Cohen and Pascaline Dupas, the one that was, it was published in the Brookings first in 2007. It's called Free Distribution or Cost Sharing Evidence from a Randomized Malaria. That's a really great resource. I think in terms of understanding the debate about whether to do social marketing or commercial distribution versus mass campaigns, there's another article called Quick Wins versus Sustainability, Options for the Upscaling of Insecticide-Treated Nets. That really lays out sort of the argument. If you're interested in the longer history, a book that I read for this that was really informative and helpful is The Making of a Tropical Disease, A Short History of Malaria by Randall Packard. And of course, also just another plug for this case study, which is not, I think, online yet, but by Monday, Tuesday, it should be online. And that also, it's very extensively cited. So if you can definitely check that out for more ideas too.
Wow, I love how excited you got with the resource dumping. So you shared like 4 really good stuff. Hopefully the audience could capture it. I'm gonna send it more in the chat. We are down to our last minute. And since in EAGxVirtual or any EA conference, we are especially excited for folks to get to take action after all the awesome learnings. So I guess like in the last 1 minute that I could yield back to you, Cordelia, what are some actions that you would highly recommend folks to take after this conference?
Okay, I think in terms of malaria, I think definitely just getting a sense. Oh, I honestly have a terrible answer to this. So sorry to cut me off guard. But I think definitely just getting a sense of again, the like politics behind it. There's another resource and I'm forgetting the name of the title. But Yeah, I'm sorry. That's such a terrible answer.
No, oh no, no pressure. You could also wrap up. We could also wrap up here with like just like a maybe one sentence thing that you could like to leave the audience with.
I just say thank you so much for joining and listening, and definitely really hope that I'm sure that since you're participating in this conference, you're very motivated to do good in the world. So I totally wish you all the best in that. And yeah, thank you so much.
So much, Cordelia.